Hello everyone. Hope you are having a great day. I can recognize that some of you have already attended the last webinar. Okay, so welcome back, guys. The last webinar was at the high yield neuroanatomy, and we posted it on the channel. It was very good, and I believe it was very important also. For example, Raza here attended it, Sumaya and Iyad. You can like exit and or he can't hear me, so exit and rejoin again. Yeah. Now, I will just introduce myself very fast, guys, so I don't waste your time. So again, welcome back. My name is Karim, and I am the head tutor at the Match Guy. I scored 279 on my step 2 exam, of course, and I have been tutoring for 5 years right now. Today, what we are going to do is that we are going to go through the most important and the most high yield hematology questions. Of course, it would be a challenge to go through everything in hematology in 1 hour, but I would say we will try to cover at least 70% of these hematology, and we will try, and that would be the function and the goal of this session is that after the session itself, once you see any question on hematology, at least you understand how can you approach it. Because I believe the most important thing is not me telling you information and that's it, but it would be me telling you how the question will show up in the exam and what's the best way to answer it on the exam itself. Probably in the future, we will need to, I will introduce many webinars along with our amazing tutors. So hopefully, after a few weeks, we'll also increase this recording frequency, guys. So let's start. Let's not waste your time and let's start with the hematology right away. And the way we are going to do hematology, guys, is that we will do the blood first, and then after the blood, which is the anemia, what I mean, we will go through the platelets, and then after the platelets itself, we will go through the leukemia and the lymphoma, guys. Okay, so these are the three things that we will be trying to readdress with each other. So anemia and platelets, and then leukemia and lymphoma, and how we can answer all of them on the exam. So let's start with the anemia first. And again, the most important thing is that I give you one information in order for you to be able to answer the question on the exam. So whenever I answer an anemia question, guys, and they show me a person and this person is having pallor or anemia, the most important thing I need to figure out first is what type of anemias you're talking about. And the easiest way to do this is by looking at the mean corpuscular volume, which is the size of the RBC itself. And you probably know, guys, but if the mean corpuscular volume is more than 100, then I know they are talking about a macrocytic anemia, especially megaloblastic anemia. And then if it's 100 to 80, I know they are talking about normocytic anemia. And then if it's less than 80, I know they are talking about microcytic anemia. Now, the biggest challenge I see students face is that they don't know if this type of anemia is microcytic, normocytic, or megaloblastic. And I will give you an easy way to remember them. And also an easy way to know what they will actually ask about for them on the exam. So let's start with the most important and the most high yield one, megaloblastic, guys. So usually megaloblastic anemia happens when you have a problem on the DNA synthesis. And think about it this way, guys. If you have a big red blood cell and you need this big red blood cell to proliferate into two daughter cells like this, what do you need to do in order for this big RBC to proliferate into two daughter cells? You need this RBC DNA to replicate. You need the DNA to replicate. You need DNA replication, right? Now, the problem here, guys, is that this person, or usually what happens, is that sometimes there is a specific vitamin called the B12 and the B9. These B12 and the B9 vitamins, guys, can are very important to make your DNA, especially very important to make pyrimidine. And if the person is having B12 or B9 deficiency, they will not be able to make pyrimidine, okay, which is adenosine, for example, and like the thymine and cytosine. If you can't make pyrimidine, you will not be able to make the DNA itself. and the person will start to have megaloblastic anemia, and his cell will be big. Not only the RBC that will be big, guys, but also, which is very important, the neutrophils. The neutrophils will be very large, and the person will have something called hypersegmented neutrophil. And that's extremely important. So once they mention a hypersegmented neutrophil, larger neutrophil, or they mention a person with increase in the mean corpuscular volume, that would be either B12 deficiency or B9. Now the question is, and that's what they ask, how I differentiate between B12 deficiency and the B9 deficiency. And the answer is very easy. We have two things that we need to differentiate. We have usually methyl malonyl CoA, guys, methyl malonyl CoA, and we also have another substrate that we need to measure that's called the homocysteine level. The homocysteine level. Okay. Now, methyl malonyl CoA and the homocysteine, both of them will be increased in B12, but only homocysteine will be increased in B9, and the methyl malonyl CoA will be normal in B9. The way I remember it is that B12 is 1, 2. So the two of them are high. Methyl malonyl CoA is increased, and at the same time, homocysteine is increased. On the other hand, the B9 is only one thing that would be increased, which is the homocysteine. Okay. The other very important thing, guys, is that B12 will cause neurological manifestations. It can cause something we discussed before, which is called subacute combined degeneration, but B9 will cause no neurological manifestation. The third very important differentiation is that B12 deficiency will happen in strict vegans. Okay? But B9 will actually happen in people that do not eat vegan. They do not eat plant. And the reason for this is that B9 is found in plant, but B12 is found in animals. So if you have a vegan person, they will have normal B9, but they will have B12 deficiency. And a question they ask is that you need to be vegetarian for 5 years in order to get B12 deficiency, because it can be stored in the liver for up to 5 years. So that's literally everything about megaloblastic anemia they can even ask about on the exam, guys. Okay? They can even ask about on the exam. The methyl malonyl CoA level, the homocysteine level, the DNA synthesis problem. They ask about this question especially. What's the problem in megaloblastic? Problem in DNA synthesis, and the hypersegmented neutrophils, because they will show you a question about it on the exam. Okay. Now, of course, Iyad, there is very many other causes of megaloblastic anemia, like orotic aciduria, which is also problem in pyrimidine synthesis, and alcoholic patients also. Okay. And these ones are the most important and the high yield ones. Now, let's go into the microcytic anemia then. So we discussed the megaloblastic. Let's go into microcytic anemia. How do I remember the causes of microcytic anemia? Very easy, guys. What happens in microcytic anemia? You cannot make the red blood cell. You cannot synthesize RBCs. That's why the RBCs and the hemoglobin are very small in size. So the problem here is that you cannot make hemoglobin. There is problem in hemoglobin synthesis. How do you usually make hemoglobin, guys? Usually you make the globin first by alpha chain and beta chain. And usually you make the heme by iron and also protoporphyrin. Okay, guys? So if you have any problem of these things we discussed, you will have microcytic anemia. For example, alpha and beta. What is this? What can cause problem in alpha and beta chain? Thalassemia, right, guys? Isn't thalassemia problem in making alpha chain, alpha thalassemia, or beta chain, beta thalassemia? So thalassemia can cause microcytic anemia. Thalassemia usually cause target cells, guys. It can cause target cells. And one of the important things also I need you to know about thalassemia is that it can be problem in specific chromosomes, for example, thalassemia alpha, chromosome 11 or whatever, but they will ask you what's the problem in thalassemia? Something called spliceosomes or splicing mutation. The problem in thalassemia is a splicing problem. That's very important they ask about. We have problem splicing the DNA into introns and axons, guys, or exons. That's a very important question. Okay. Now, how about iron? What can make problem in iron? Very easy, iron deficiency anemia. Iron deficiency anemia. And usually it depends. How do you get iron deficiency anemia? If you are a kid, you can get iron deficiency anemia if you have poor nutrition. You don't take it from your diet. If you are an old person, you can get iron deficiency anemia either from colon cancer or from peptic ulcer that can cause bleeding in the GIT. This can cause iron deficiency anemia, right? Also, if you are a person that have eosinophils, they will tell you we have a person with eosinophils in the blood and the iron deficiency anemia, then I need you to suspect parasite infection, something called the Necator americans. This one, guys, this is a specific parasite that can also cause iron deficiency anemia. We call it Necator americans. I remember Necator. It starts to cause GIT bleeding, this specific parasite, and it can cause iron deficiency anemia. This is different from a specific parasite called the D-latam, which is usually called the fish worm that can cause B12 deficiency. Okay, I am just trying to give you all the high yield stuff that I have seen them asking about iron deficiency anemia itself. Okay, and then if you have problem making a protoporphyrin, you can also get microcytic anemia. So what do we call a problem in protoporphyrin synthesis? We call it usually sideroblastic anemia. Sideroblastic anemia. Okay. It can happen usually from a specific enzyme called synthase deficiency, or it can happen if you have B6 deficiency. And I wanted to ask you guys, what drug can cause B6 deficiency? And this will cause sideroblastic anemia and iron deficiency anemia. What do you think? What drug can cause B6 deficiency? It's very important. Amazing, amazing, perfect, guys. Perfect, Ahmed, perfect, Rosé. It would be isoniazide. Isoniazid, guys, usually can cause severe B6 deficiency. This can cause peripheral neuropathy, and this can also cause sideroblastic anemia. Okay, and we talked about sideroblastic anemia can also happen from synthase deficiency. Okay, also porphyria can cause this problem sometimes. If you have porphyria, we have two porphyria. We have porphyria cutanea terda. This can usually cause cotinea, so cutaneous, so it can cause cutaneous lesions, the skin blistering. Or we have something called an acute intermittent porphyria. This one I remember, acute intermittent, so it can cause acute intermittent painful abdomen and also can cause black urine. Okay, guys, and the peripheral neuropathy. So this is the protoporphyrin itself. Now, I need to go and discuss with you guys how can you get iron problems. Okay, so we say it's the most common cause of getting iron problem is iron deficiency anemia. And in this one, guys, if you measure the serum iron, it will be low because you have iron deficiency anemia. It makes sense. If you also measure the ferritin level, okay, the ferritin level, and what is the ferritin level, guys? The ferritin level is usually the storage form of iron. So if you have iron, how do you store it in the macrophage and the liver is called the ferritin. It will also be low because you have iron deficiency anemia in general. Okay. And if you measure the total iron binding capacity, you will see that it's high because you have high capacity for iron. Okay. And because you don't have any iron, so you have high capacity for it, you need to usually transfer it. Okay. And if you measure transferrin saturation, you will see that transferrin saturation is low because you have iron deficiency anemia, so transferrin is not saturated with enough iron. So that's iron deficiency anemia. Now we have a different cause that can cause problem in iron, and we usually call it anemia of chronic disease. This one usually cause normocytic anemia, but sometimes it can cause microcytic anemia, anemia of chronic disease. Okay, and I need to tell you something, guys, about anemia of chronic disease. And this thing that I need to say is that how does it happen, Iyad? Yes, Iyad, in the iron itself, total iron binding capacity, okay, is always high and the ferritin itself is low, okay? This can be a little bit different in anemia of chronic disease and we'll talk about it. But let's talk about what is anemia of chronic disease first, guys. So I will tell you something. Anemia of chronic disease usually happens if you have chronic inflammation. And I need you to understand why. Why, when you have chronic inflammation, you get anemia of chronic disease? The answer is very simple. If you have a chronic inflammation, guys, the body will think that you have an infection. So sometimes, for example, you get rheumatoid arthritis. But the body, because the body sees elevated cytokines, so the body thinks that there is too much infection. Okay? So what will happen is that the body will need to do a very important thing. It need to hide iron from the blood. Why? Because normally bacteria eat iron. So if you have infection, you need to hide iron. And that's why if you have chronic inflammation, the body will try to hide iron. How can the body hide iron? The body can do this by increasing hepcidin, and I always remember hepcidin hide iron. So it will cause decrease in the serum iron. Okay, it will hide the iron in the serum. But what will happen to ferritin? Did we say where it hide in? It hide it in the liver and in the macrophage, in the ferritin itself. So the ferritin will be high. The ferritin will be high. So the person will have decreased the serum iron and increase in the ferritin level. Okay? And that's what we call anemia of chronic disease. The person will have decreased serum iron level, but increase in the ferritin level itself first, right? So that's how I answer these things about anemia of chronic disease and iron deficiency anemia. Now, look at this. Usually, the total iron binding capacity IAD will be low, and the transferrin saturation will be low in anemia of chronic disease, but they will not ask us about this. I always need to give you the least amount of information to answer the question. How would I always answer the question? By looking at the ferritin level. If it's high, then I know it's anemia of chronic disease. If it's low, then I always know it's iron deficiency anemia. Okay, but the total iron binding capacity will be low in anemia of chronic disease actually. Yep, yep. Okay, yeah. Now let's look at this good image here. So now we know that megaloblastic anemia happens when the DNA is affected. This can happen in folate, vitamin B12, orotic aciduria, or microcytic anemia happens when the hemoglobin itself is affected. This can happen if you affect the alpha chain, beta chain in thalassemia, or if you have anemia of chronic disease, iron deficiency anemia, and the lead poisoning. Lead poisoning, you guys, is very important because lead poisoning can affect protoporphyrin, so it can cause sideroblastic type anemia, and the lead poisoning will always cause below dots in the RBC like this, and we call it basophilic stippling. Basophilic stippling. And they will always ask us about this. Okay, they will always ask us about this. How I always diagnose lead poisoning on the exam, Rosé. Lead poisoning on the exam will always be diagnosed when I see a person, usually a kid, living in an old house, and they are having mental problems. For example, they are getting low grades on the school, for example, and they will always show me this picture of the basophilic stippling. Okay. Now, it can cause similar to sideroblastic anemia rosé. But when they say sideroblastic anemia, they usually mean the B6 deficiency or the ALA synthase deficiency. But it's literally the same thing. Okay? It's literally the same thing. Or sometimes all the paint can also cause lead poisoning itself or lead poisoning symptoms. Okay? The most important thing is you will see peripheral neuropathy, you will see mental problem, and you will see microcytic anemia. You know you are suspecting lead poisoning here. Okay? Now we know all the causes of microcytic, all the causes of macrocytic. Other causes will be normocytic, guys. Other causes will be normocytic. Okay? And it depends. Once I see a normocytic anemia, do you know what's the first thing I need to look at? What do you think, guys? When I see a normocytic anemia, what's the first thing I always need to look at the laboratory? Always, always, always look at this rosé. Look at the amazing reticulocyte, okay? Reticulocyte count. If the reticulocyte count is increased, that would be something. If the reticulocyte count is decreased, that would be another thing. Usually, guys, what is the reticulocyte? The reticulocytes are usually the cells that make the mature RBCs in the bone marrow. These are the reticulocytes. So, baby blood, as Carolina said. Okay. So if the reticulocyte count is low and at the same time the RBCs are low, it means you have a problem in the bone marrow itself. So for example, you have aplastic anemia or you have myelofibrosis, okay? But if the reticulocyte count is high, it means your bone marrow is working fine. So it probably means you are having something that destroys the RBCs from outside. And as Dill said, this can be something like hemolysis. Okay? This can be something like hemolysis. And I don't care about all the causes of hemolysis. I will give you one word that will make it easy for you to know all the causes. But what I care about, guys, is that hemolysis will cause too much reticulocyte. It will cause too much lactate dehydrogenase because lactate dehydrogenase will be secreted from the RBC. It will cause too much bilirubin. The only thing that hemolysis will decrease will be haptoglobin. Haptoglobin will decrease, right, Ajay, if you have hemolysis. That's a question that's extremely high yield that will show up on the exam. So hemolysis will cause too much retics, too much LDH, too much bilirubin, but the only thing that it would decrease will be the haptoglobin itself. It will decrease the haptoglobin level. Okay, guys? That's very important. That's very important. Okay? Now let's talk about this. So we said if you have low reticulocyte count, then it's non-hemolysis. It's a problem in the bone marrow. For example, anemia of chronic disease early on. For example, aplastic anemia. For example, chronic kidney disease because you will have decreased erythropoietin, so the bone marrow cannot synthesize RBCs, and sometimes acute blood loss. But I don't want you to remember this. Okay. Then if you have high reticulocyte count, that's a hemolytic anemia. Now I don't care about extrinsic, intrinsic. I will give you one word I need you to know about each one. Hereditary spherocytosis. This one will cause increase in something called the heme corpuscular concentration, the concentration of hemoglobin. Once you see the concentration of hemoglobin is increased, that would be hereditary spherocytosis, the MCHC. Exactly, amazing, Iyad. And the only thing I want you to know about the hereditary spherocytosis is that it will be a problem in the cell membrane in a specific gene called ankyrin and the spectrin. So these are problems on the cell membrane. It make usually the membrane spherocyte like this, not like the normal RBC. And this will cause the spleen to destroy these RBCs because they look spherocyte in shape. They don't look normal in shape. And that's why the spleen will destroy them. Okay. And usually the problem is the ankyrin and the spectrin, and these are autosomal dominant. It's an autosomal dominant disease. And it happens in European people. So they will tell you, for example, a person from Holland country, from Norway, for example, Norwegian, and they will tell you that this person, his father, had splenectomy. Why? Because the treatment of hereditary spherocytosis is a splenectomy. Didn't we say that the problem is that the RBC is a spherocyte, so the spleen destroyed? So usually if you do splenectomy to the person, then the problem would be solved. You will not destroy it anymore. So they will tell you his father underwent splenectomy. And now this person is having hemolysis and gallstones from the hemolysis. They will ask you what's the diagnosis? Hereditary spherocytosis. How how do you treat it? By splenectomy. If you do splenectomy, what would you see? You will see something called the whole body. Whole body. Just remember this name. If you do splenectomy, you will see this. What's the inheritance? It's autosomal dominant. Okay. Then we have a disease. So this is for hereditary spherocytosis, guys. Very easy increase in the MCHC, and the person will have ankyrin spectrum problem, autosomal dominant. Paroxysmal nocturnal hemoglobinuria, on the other hand, will cause one important thing. From the name, paroxysmal, so episodic, nocturnal hemoglobinuria. So during the night, the person will have hemolysis. So usually they will tell you at the morning, they have dark urine because during the night, they get hemolysis. And usually they also have pancytopenia. So all the cells, not only the RBCs, are low. Okay. Now, do you know, guys, what's the problem in paroxysmal nocturnal hemoglobinuria? Why your cells gets destroyed like this? Why in paroxysmal nocturnal hemoglobinuria the cells get destroyed like this? Okay. Yes, guys, amazing, amazing. So there is usually problem is that normally This is the red blood cell here, and the red blood cell have a receptor called the GBI or the DAF, okay? And this GBI, guys, protect the RBC from being destroyed by the complements. Now, a person with paroxysmal nocturnal hemoglobinuria have problem in this GBI or the anchoring protein or DAF, have problem in this receptor CD55, 59. So what happened is that the complement start to destroy the RBCs. Not only the RBCs, but the other red blood cells and the other plasma cells. So you will get pancytopenia. Now, what's the questions they will ask about in the exam? Extremely high yield. They will tell you what's the most important complication of paroxysmal nocturnal hemoglobinuria. And it's always venous thrombosis, like for example, hepatic thrombosis or Budd-Chiari syndrome. So these people have a very high risk of getting venous thrombosis, guys, like Budd-Chiari syndrome, which is hepatic vein thrombosis. Amazing, Iman, amazing, Mustafa. So that's very important, guys, regarding the hereditary spherocytosis and the paroxysmal nocturnal hemoglobinuria. For the enzyme deficiency, we have G6PD. This will usually cause problem in making a NADPH, which is important to protect you from oxidative free radical. How would you get it on the exam? Usually it's X-linked, so you will see it in a boy, and this boy is having a hemolysis after taking a drug. If you see a kid with hemolysis after taking a drug, like sulfa drugs, for example, as Mustafa said, then it would be G6PD deficiency. We have sulfa drug, we have dapsone, we have brimaquine, which is a drug used to treat malaria, guys. Okay, drug used to treat malaria. Okay, now the other one here is usually pyruvate kinase deficiency. That's the second most common cause of hemolysis in enzyme deficiency. How do I diagnose it? They will just give you a kid with hemolysis with no reason for it. And they will ask you why. The answer is pyruvate kinase deficiency. And that's it. Okay. Now, I believe, Iyad, is it because you treat, so how do you treat mishemoglobinemia? I think you treat it with methylene below. And yeah, I believe the only thing that can be associated with them is that both of them can be caused by drugs like dapsone or nitrate. That's the only thing I can associate mishemoglobinemia with G6PD that comes into my mind. That both of them can be caused by similar drugs. Okay. Now, one thing that I need you to know, guys, is also sickle cell and the hemoglobin C. So what is sickle cell and the hemoglobin C? These ones are problems in the hemoglobin. It looks weird. Sickle cell, the hemoglobin looks sickled, right? And you will see increase in hemoglobin S. Hemoglobin C, you will also see something called RBC's crystals. What's the main difference between sickle cell anemia and the hemoglobin C disease? Is that both of them are genetic problem. The only difference is that there is problem or buoyant mutation that will transfer glutamate to valine, that's in sickle cell, and to lysine, that's in hemoglobin C. So if they tell you there is a point mutation that transferred glutamate to valine, then we are talking about sickle cell disease. If this transfer or point mutation transferred glutamate to lysine, then we are talking about hemoglobin C. That's the difference between them. Now, students struggle to diagnose sickle cell, right? And I always tell them you struggle to diagnose sickle cell because you think that sickle cell usually cause anemia. Most of the time, you diagnose sickle cell not from the anemia, but from the pain symptoms. Sickle cell will usually cause sickling of the RBCs, so you will see obstruction of the RBCs in many arteries. So, for example, you will see obstruction of the RBCs in the venous. So the person will have something called the periapism. Okay, you will see obstruction of the RBCs in the fingers. So the person will have something called the dactylitis, which is painful fingers. Periapism is usually prolonged erection. You will see obstruction in the chest. So the person will have acute chest syndrome. The most common cause of this in sickle cell patients, if they usually have, if they usually grow into adults. Okay, you will see obstruction in the spleen. So people with sickle cell will have something called auto splenectomy. The spleen will get removed directly from the body because there is obstruction of the spleen vessel, and they will get increased risk of the encapsulated bacteria, which are Streptococcus, Haemophilus influenza, and Neisseria. So this is how you diagnose sickle cell. How they ask about it. They ask about the complications. They ask about the glutamate valine. They don't ask usually about why it causes anemia or something like this. Okay, guys? So that's very important. And of course, if they have splenectomy and they get increased risk of the shunts, then you need to give them the conjugated vaccine. Okay, conjugated vaccine. Now, then we can have something called autoimmune hemolytic anemia, guys. And autoimmune hemolytic anemia, the only thing I need you to know that we have cold, we have worm. Cold, worm. Cold, worm. The cold one is usually IgM. There is IgM antibodies attacking the red blood cell. The warm one is usually IgG. Okay. Remember the mnemonic good weather. So the G, good weather, warm. So you have a good weather, which is warm weather. The good weather is a warm weather. So IgG is warm, but IgM is the cold one. Okay, guys? Now, please know this fact. I just want you to know one example on the cold that they will always ask about it. Okay? Do you know what's the most important example that can cause cold autoimmune hemolytic anemia? There is many examples. There is many examples, but this one is very important, guys. Yes, amazing. Mycoplasma pneumonia can cause cold autoimmune hemolytic anemia. Mycoplasma pneumonia can cause cold autoimmune hemolytic anemia. It's one of the causes of atypical pneumonia, and it's extremely important, boys here. Okay, you need to know it. You need to know it, Kahla. Okay, so mycoplasma pneumonia will cause IgM, cold autoimmune hemolytic anemia. Okay, the other things like worm, for example, will be anything else. Epstein-Barr virus, worm. Systemic lupus, worm, whatever. I don't want you to remember them. Drugs, worm, whatever. I just want you to know mycoplasma, cold. That's the most important thing. That's the most important thing. Okay? So now that's for the autoimmune hemolytic anemia, the cold and the warm. And of course, they will cause something called the positive comb test. Once you see the word the positive comb test, it means there is positive autoantibody. Okay, guys? Okay, guys? So that's for the autoimmune. Now, here comes the most difficult one, micro and macroangiopathic hemolytic anemia. And usually students struggle to get it. So let's do it with each other in a very simple way, guys. Okay? Usually you have a disease, it's combined diseases together called microangiopathic hemolytic anemia. And the way I need you to think about it, guys, is that if this is the red blood cell, this is usually the red blood cell. Sorry, usually the blood vessel. And this is the blood vessel that supplies the kidney. So let's say this is the blood vessel that supplies the kidney. What happens in microangiopathic hemolytic anemia is that you get small platelets that make thromboses like this. Okay? And when this platelets make thrombosis, when the red blood cell try to move, it will not be able to move. So it will be destroyed. Okay? And this tells us all the symptoms of microangiopathic hemolytic anemia. The first thing is that this happens in the kidney. So you will see kidney damage. The second thing is that it happens from platelet thrombosis. So you will see decreased platelets. The third manifestation is that the RBCs gets destroyed. So you will see hemolytic anemia and you will see schistocytes. It gets destroyed to always have the schistocytes. Okay? Most of the time, Iyad, and I will tell you the difference. But most of the time, guys, once you see decrease the platelet, decrease the hemoglobin, schistocytes, and the kidney damage, always think about microangiopathic. It happens in the small blood vessels, hemolytic anemia, because it can cause hemolytic anemia. Okay? Now, what are the causes of it? We have TTP. Does this one cause it or not? Yes. And we have hemolytic uremic syndrome. And then we have GIC, right? Amazing, amazing, perfect, perfect. And then what else? What else, Crystal, can we get? What else can cause microangiopathic hemolytic anemia? ITB will never cause this, Muhammad. Never. TTB only. ITB cause only decreased platelets, nothing else. Okay. And then the last thing is HELB syndrome. HELB syndrome that happens in pregnancy. Okay. So let's see here, guys. So this person, not systemic lupus Sophia, but something called scleroderma renal crisis, but it's not important for step one. This is for step two, scleroderma renal crisis. Now, I will tell you guys this, all these four things can cause schistocytes. All of them can cause kidney damage. All of them can cause decreased hemoglobin, decreased platelets. Yes, Andrea, but this is called the macroangiopathic. We'll talk about it, okay? Now, let's go here. TTB, what I need you to know is that it happened in adult woman, and it's usually problem in something called Adams 13. How do I think about Adams 13? I think about Adams 13 from the word 13 or from the number 13. I remember that Adams 13, you have 13 vulnerable brand factor multimers connected to each other. And because they are connected to each other, they make platelet thrombosis. And they will make this person to have microangiopathic hemolytic anemia. So if you see an adult woman with decreased hemoglobin, with decreased platelet and schistocytes, that would be TTB, not ITB. And this will be problem in Adams 13. On the other hand, if you see a kid that's getting decreased hemoglobin, kidney damage, and schistocytes after EHIC, which is usually enterohemorrhagic E. coli that can cause bloody diarrhea, then think about hemolytic uremic syndrome. Okay? Think about hemolytic uremic syndrome. If you see a person that's going into a trauma and they are having oozing of blood from the IV vessels or from the IV catheters, that would be DIC, disseminated intravascular coagulopathy. So if you see a person that has oozing of blood from the intravenous catheter, oozing of blood is the key word for DIC. And after trauma, that's DIC, guys. And DIC will cause something very important. It will cause everything to be consumed. So if you have DIC, you will consume the platelets. So you will have decreased platelets. You will have increase in BT and the BTT because you are consuming the coagulation factors. You will consume fibrinogen and you will make fibrin. So fibrinogen will be decreased, and the fibrin and the D dimer, something called the D dimer, will be increased, which is fibrin split products. Okay, so DIC consume everything, and it makes thrombosis and hemolysis at the same time. So you have low platelets, you have too much BT and BTT, you have decreased fibrinogen, but too much fibrin and D dimer and the fibrin split products. That would be DIC, guys. Okay, then HELP is usually a pregnancy complication of preeclampsia. It usually causes the H hemolysis because it can cause microangiopathic hemolytic anemia. The EL for elevated liver enzyme, and the B because it can, or the LBE because it can cause low platelets. Because we said if you have microangiopathic hemolytic anemia, you will cause hemolysis and the low platelets, and it also causes elevated liver enzymes. That's the HELB syndrome: hemolysis, elevated liver enzymes, and the low platelets. Okay, guys. So these all the causes of microangiopathic hemolytic anemia that can cause schistocytes or helmet cells. Schistocytes or helmet cells. Now there is an additional bonus cause, but we call it macroangiopathic because it happened in the large blood vessel of the aorta. This causes aortic stenosis or prostatic aortic valve. If you have synthetic aortic valve or aortic stenosis, guys, what will happen to the RBC when it try to move through it? It will be destroyed, right? You will see schistocytes. So usually if you have severe aortic stenosis or prostatic aortic valve, then it can cause also schistocytes, and we call it macroangiopathic hemolytic anemia. So all of these guys were the causes and different causes of anemia. Okay, so if we would repeat it in just 4 minutes, we said macrocytic will usually be problem or too much mean corpuscular volume, and that's a problem in DNA. So folate, vitamin B12, orotic aciduria, things that cause problem in DNA, and it will always cause something called hypersegmented neutrophils. These are the hypersegmented neutrophils, 1, 2, 3, 4, 5, 6, multiple segments of neutrophils. Then the microcytic is problem into making the hemoglobin. So either you have problem making globin, like thalassemia, that's usually a splicing site problem, spliceosome, or you have problem making heme, like for example, anemia of chronic disease, iron deficiency anemia, lead poisoning, and sideroblastic anemia. Okay. Then we took the normocytic, look at the reticulocyte count. If it's low, then it's a problem in the bone marrow, like aplastic anemia or chronic kidney disease. If it's a high, then it's a hemolysis. The hemolysis parts, we know one word about them. Okay. So, for example, if it can be membrane defect like hereditary spherocytosis, ankyrin spectrin, it can be paroxysmal nocturnal hemoglobinuria, which can cause venous thrombosis and pancytopenia, and it's a problem in the complement, GBI. It can be after taking drug G6PD or just hemolysis without a specific reason by pyruvate kinase. It can be severe, painful crisis like sickle cell, glutamate versus valine. Or it can be that you will see crystals in the hemoglobin, crystals, hemoglobin C, glutamate versus lysine. It can be an autoimmune like IgM or IgG. The cold is the IgM, mycoplasma. The warm is the IgG. It can be microangiopathic hemolytic anemia like TTP, hemolytic uremic syndrome, DIC. It can be macroangiopathic hemolytic anemia. This one deal will be if you have severe aortic stenosis. The RBCs will not be able to pass through this aortic stenosis, right? So the RBCs will get destroyed. So you will see helmet cells. So if they tell you we have an older person with, like, let's say, crescendo decrescendo murmur at the right second intercostal space, and this person is having iron deficiency anemia, or sorry, normocytic anemia and hemolysis. What can be the cause? So systolic murmur at the second intercostal space, that would be aortic stenosis, and aortic stenosis can cause anemia by causing macroangiopathic hemolytic anemia, which will cause schistocytes. Okay, guys? So that was all the anemia and how we can diagnose them. Okay? Thank you, guys. Thank you, Kahla. I appreciate it. Now, let's go. So this was the anemia part. Okay? Let's go through the bleeding part because I believe students always struggle from problems in bleeding. Now you can see these fancy images we are making. We can go through these fancy images, but I usually love to explain these things in whiteboard because I need to tell you how can you answer this bleeding disorders, guys, how you can actually answer them on the exam. Okay, so here is the thing. So for the bleeding disorder, guys, for the bleeding disorder, okay, what I need you to know is that we can get bleeding by three ways. Either your collagen is bad, you have weak collagen, okay? And this can happen usually if you have vitamin C deficiency. And we call this disease scurvy, okay? We call this disease scurvy. So either you have a very weak collagen, and this can happen in vitamin C deficiency, and we can call it scurvy. And that's it. This can cause bleeding, and it makes sense because we know scurvy can cause usually gingival bleeding and the perifollicular bleeding. Okay, but it's not a problem in platelet or coagulation factor. Or if you have problem in platelets, you can also get bleeding problem, right? Now, what can cause problems in platelets, for example, guys? Either there is something destroying the platelet, so damage to the platelet itself, okay? So damage to the platelet itself, or there is something that causing a problem in the function of the platelet. So either platelet damage or platelet function. Okay, I will explain very fast what's the function of the platelet, so you can know how do we diagnose these conditions. So the function of the platelet, guys, is that we need the platelet to adhere to the endothelium, to adhere to the endothelium. And the way it will do this is by GB1 receptor. Just remember 1A receptor or whatever. Okay. And also by von Willebrand factor. Usually von Willebrand factor and GB1A will be very important for the platelets to bind to the endothelium itself. That's the first function. Okay. The second function, guys, is that we need these platelets to aggregate with each other, to combine with each other. And the way they will do this is by another receptor called GB2A or GB2B3A. So remember, one, the first thing is platelet adhere. So it adhere with the receptor called 1 and by von Willebrand factor. Okay. Two, the second thing is that we need the platelets to aggregate. And they aggregate by the second receptor GB2B and 3A. Okay. So that's the function of the platelets. And any problem in this function can cause problem in platelet function. Okay. And then we also have coagulation factors. We will talk about the diseases, guys, afterward, okay? We have coagulation factors. And these ones function, guys, is that usually platelets make a thrombi, but very weak thrombi, very weak thrombi. So the function of the coagulation factors is to make the thrombi stronger, to make a strong thrombi. And usually we have different coagulation factors depending on the pathway. We have something called intrinsic pathway, and we have extrinsic pathway. And it's really very easy, guys. Intrinsic pathway is almost most of the coagulation factors. Coagulation factor number 8, number 9, number 11. We skipped them. Okay, these are the intrinsic coagulation factors. On the other hand, the extrinsic one will be only coagulation factor number 7. Okay, so please, guys, know this fact. I need you to know this fact. So intrinsic coagulation factor will be number 8, number 9, number 11. Extrinsic coagulation factor will be number 7. Okay. And something I need you to know, and it's extremely and very important, is that how do you monitor all of this? So if I need to monitor the extrinsic, I monitor it with something called BT, partial thromboplastin. If I need to monitor the intrinsic, I monitor it with BTT. So remember it this way. BT, two characters only. Okay, so it's only one coagulation factor, the small one, coagulation factor number 7. BTT is larger, right? Or BBT or whatever. BTT is larger. So you will monitor the biggest coagulation factors, 8, 9, and 11. 8, 9, and 11. Okay, so the BTT will monitor the too much coagulation factors, the intrinsic one, 8, 9, 11. And the BT is only one thing, which is 7. Then we have something called common pathway. This one is usually shared between intrinsic and extrinsic. And the common pathways are like, remember it this way, 2 multiplied by 5 equal 12. So 2, 5, 12, sorry, 10. 2 multiplied by 5 equal 10. 2, 5, and 10 will usually be the common pathway. If you have problem in the common pathway, then both BT and the BTT will be increased. Both of them. This is the common pathway. So again, the extrinsic is 7, BT only. So if you see a person with increasing BT, that's extrinsic. If you see a person with increased BTT, that's intrinsic 8, 9, or 11. If you see a person with increase in both of them, that's a problem in the common pathway like 2, 5, or 10. Okay, guys? Now, let's go into how do I diagnose these questions on the exam. So first, how do I know it's a coagulation factor, collagen problem, platelet problem, coagulation factor problem? The first way to know this is that by looking at the type of the bleeding. If it's a bleeding in the gum or perifollicular, that's a collagen problem, scurvy. If it's a superficial bleeding, like for example, ecchymosis, like BTKA, something you can see with your eye, like epistaxis, then it would be platelet problem, okay? And if it's a deep bleeding, like for example, joint bleeding, hemarthrosis, joint, or dental extraction, bleeding after dental extraction, then it would be coagulation factor problem. So the first thing I always look at is I look at the type of the bleeding. Superficial bleeding will be platelet, deep bleeding will be coagulation factor, gingival or perifollicular will be collagen problem. Okay. The second thing, let's say I see a superficial bleeding like epistaxis Mustafa or like ecchymosis or BTK, and I know it's a platelet problem. And this is supported because I know platelet problem will cause increase in something called the bleeding time. Bleeding time. Okay, Mariam? So the bleeding time itself, and welcome to this session, okay? So if I see increase in bleeding time, I know this is usually a problem in platelet, and my next step is I need to look at the platelet number. If the platelet number is decreased, this means there is something that's damaging the platelet. This can either be ITB, because we know that ITB, there is antibodies attacking the platelet, guys. Okay, Crystal? There is antibodies attacking the platelet. Okay? Or it can be TTP, or hemolytic uremic syndrome, or any microangiopathic, because we know these things also decrease the platelet, but you will see that they have also decreased the hemoglobin and schistocytes, if you remember. So if you see decreased the platelet only, please guys, if you see decreased the platelet only, it's always ITB. It's nothing else. If you see this middle-aged woman or this young kid after respiratory tract infection have decreased the platelet only, that would be ITB, which is autoantibodies against the platelet like receptor, something called the platelet receptor 4 or 5 or whatever, and it's destroying the platelets. Okay? But if it's decreased the platelet with decreased the hemoglobin with kidney damage, then it would be microangiopathic hemolytic anemia like CTB or hemolytic uremic syndrome. Okay. Now, how about the bleeding time is high, but at the same time, the platelet number is normal. Then it means it's a problem in the function. If the bleeding time is high, but platelet is normal, it's a problem in the function itself. So as Mustafa said, we don't call it thrombocytopenia because there is no decrease in platelet. We call it thrombocythemia, which is problem in the function of the platelet, but the platelet numbers are fine. And what can cause this? Very easy, Mariam. Anything that can cause problem in the function we talked about. So von Willebrand disease can cause problem in von Willebrand factor. Okay, so it can cause increase in bleeding time, normal platelets, and it can also cause that's very important. Von Willebrand disease, guys, focus on this one. It can also cause problem in factor 8. So you will see increase in BTT. Sometimes you can see increase in BTT because von Willebrand disease is important for factor 8. So you will see a person, and that's how I always diagnose it on the exam. Usually it's an autosomal dominant disease. Okay, guys? So they will tell me it's a female. Because if they say a male, I will think about hemophilia A, for example. So they will tell me it's a female. And this female is having mixed bleeding. For example, she has BTKA, and at the same time, she has heavy menstrual period and bleeding after the dental extraction. So it's a mixed bleeding. So I know there is problem in platelet and the coagulation factor. What's the only disease that can cause mixed bleeding because it can affect the platelet adhesion and at the same time factor 8 will be von Willebrand disease. Von Willebrand disease is always you diagnose it with mixed types of bleeding. So you can see increase in PTT and at the same time you can see increase in bleeding time, but there is normal platelets. Okay, that's von Willebrand disease. What else? So I have seen you are giving me also options, guys. We have another disease that can cause problem in GB1A, problem also in platelet adhesion, similar to von Willebrand factor. And this disease is usually called Bernard-Soulier. Okay, guys? Bernard-Soulier. This disease will usually cause problem in GB1A. It's a problem in platelet adhesion. Okay. And what I need you to know about it is that it can be similar to von Willebrand disease. They will tell you that the person is having a problem in platelet function. How do they say problem in platelet function? Increased bleeding time, normal platelets. And they will tell you that the person is having large platelets on blood smear. Big platelets on blood smear. Once you see large platelets, Bernard Soulier. Remember the B for big platelets. So Bernard Soulier will cause large platelets on the blood smear. Okay. Then we have a disease that can cause problem in platelet aggregation, which is GB2B3A. This one is called the Glenn-Zeman disease. Glenn-Zeman disease, which is problem in platelet aggregation. So now we know von Willebrand disease and the Bernard Soulier. Okay. They just have inclusions kahla that make the platelets very large. Okay, so vulnerable band disease and Bernard Soulier, both of them are problems in platelet adhesion. But Glenzeman is problem. Glens, I remember Glens is glaze. When you glaze someone, it means you are trying to connect with him, to aggregate with him, right? So Glensman would be very important. It would be platelet aggregation itself. Okay, aggregation itself. Now, one thing I need you to know, the difference between vulnerable band disease, Bernard Soulier, and the Glenzeman, we said this would be adhesion and the Glenzeman would be aggregation, is that something called restricting assay. Restricting assay or restricting test. Okay. What I want you to know about this restricting test is that it would be abnormal in vulnerable band and Bernard Soulier, but it would be normal in Glenzeman. So if they say the restricting test is abnormal, there is failure for platelets to clump together, that would be vulnerable band disease or Bernard Soulier. But if they say the restricting test is normal, then it would be Glanzmann. Okay, guys? So that's the thing about this platelet function thing. So now we talked about collagen problem, platelet either damage ITP or platelet function itself, which would be vulnerable band disease, Bernard Soulier, Glanzmann. Okay. Yeah, the problem, Ahmed, is that I always need these things to be in one board. It's better for you because if we are reviewing things in 1 hour and I am explaining them in one board, you will feel like everything is connected. That would be extremely different if I explain each disease solo. You will feel like things are starting to confuse them with each other. Okay, so that's why I love to go with them like this, the way I am doing it right now. Okay, but I will try to make it a little bit more organized for the next webinars. Okay, now let's talk about the coagulation factors, guys. So we said coagulation factors is either problem in the extrinsic and the intrinsic. So the intrinsic is usually 8, 9, 11. We said we will skip 10. And the extrinsic is usually 7. Okay. How do I monitor them? We said we monitor the intrinsic by BTT. We monitor the extrinsic by BT. Now, very easy, and it's extremely easy. That's how I always diagnose it on the exam. They will tell me a person have increase in BTT, or they will tell me increase in BT. And I will just know the diagnosis. If there is increase in BT, that would be factor 7 problem. Factor 7 problem. Okay. If there is increase in BTT, that would be either factor 8, factor 9, factor 11. Factor 8, hemophilia A. Factor 9, hemophilia B. Factor 11, hemophilia C. We said there is no 10 because 2, 5, and 10 are the common pathways. So can you see how easy it is? If you see increase in BTT, that would be either factor 8, factor 9, factor 11. Factor 8 is hemophilia A. Factor 9 is hemophilia B, the second one. And then you skip 10. Factor 11 is hemophilia C. Okay. Thank you, Carolina. Thank you, Christine. So something very important here, Sarah. Okay. And what I need you to know, guys, in order to answer these questions on the exam, is that they will give me, and that's the first thing, or the first hint. They will give me usually, okay, a person, and they will tell me, for example, he have bleeding after dental extraction. So I know, boom, it's a coagulation factor problem. Then they will show me either increase in BT or increase in BTT. If it's a BT, it's factor 7. Remember the smaller number, smaller characters. If it's a BTT, it's either 8, 9, or 11. That's pretty straightforward. Okay. Remember, if they say there is increase in BTT, but at the same time there is increase in bleeding time, and there is mixed bleeding, then it would be what? Vulnerable band disease. Vulnerable band disease. Okay, so that's all of this iris. That's how I differentiate between BT, BTT, and how do I answer them in the exam. Now, one thing, like I know we are not supposed to go through pharmacology, but something very important here is that BTT, guys, is how you monitor heparin. Remember, Heb, BTT. Heb, three characters, BTT, three characters. On the other hand, BT, which is called the INR, is how do you monitor warfarin. Okay, guys? How do you monitor warfarin is the BT. How do you monitor heparin is by the BTT itself. Okay, so that's how do I differentiate and how do I monitor heparin, BTT, warfarin, BT. One thing I always remember, and this can help you remember heparin. Heparin mechanism of action is activation of antithrombin 3 characters and the 3 numbers. So antithrombin 3, it work by activating antithrombin 3 and it increase BTT. But warfarin increase BT on the other hand. And warfarin function is by inhibiting the activation of vitamin K, something called epoxide reductase, it's inhibited. Okay. So that's also an additional thing, guys, for the coagulation factor and how do I answer it on the exam. Now, let's practice few questions with each other. Okay. And before we practice with each other, guys, this was just a glimpse of like our 7-day USMLE crash course. Usually we have the 7-day USMLE crash course and we go through all the systems. We will go through the hematology, for example, in 3 hours instead of one. So tutors usually have more time to go through the important stuff. Okay. And also, if you like my style and if you need more explanation of these topics, you can usually subscribe to my one-on-one tutoring. I usually go with my students. We make NBMEs sheet mistakes with each other. We discuss and analyze these NBMEs mistakes. If it's a knowledge gap, if it's a problem in like a silly mistake, for example, something like this, and we go through this NBMEs mistake with each other. We also make a specific plan with each other. For example, this person, I removed his name, but we make a plan. His exam is either 8th of May or 16. So we make a plan for 8th of May or a backup plan for 16. And this plan have everything, like what are the videos we will watch, what are the numbers of questions, and vice versa in the one-on-one tutoring. Now let's go into the QBank and let's practice an actual questions. And there was one question in purpose I didn't want to explain it in the review, so we see how we can apply critical thinking. This is from Synapse QBank. This QBank is for step one. It has the most high yield 1350 questions that will show up on the exam. I personally worked on this with other amazing authors, and Dr. Asad also personally worked on it. So let's go through it, guys. So a 5-year-old boy is brought to the emergency department by his parents because of 4-hour history of progressively worsening right knee pain and swelling. He was playing in the backyard when he tripped and fell onto his knees. His parents report he had a sore throat and a low-grade fever for 1 week ago. Physical exam shows a warm erythematous and significantly swollen right knee with a limited range of motion due to pain. First of all, again, I am reading this and it feels like I'm just reading it and I don't know where is my, like, I'm reading it without focus. And that's something very important, guys, is that please, when you read a question like this, you are reading it and you don't even know what they are asking about. So it feels like you are reading it without purpose. Like maybe even if I don't know if I'm answering a hematology question, I wouldn't know it's a hematology question. Like worsening swelling pain, maybe it's an MSK. So what I always recommend, and that's very important, is not reading the last sentence or anything like this, but look at the answer choices before reading the question. Looking at the answer choice will already tell you what are you talking about, what the question is talking about, and it will help you figuring out what's important. So me looking at the answer choice, I am figuring out they want me to know is it factor 7, factor 12, factor 9, factor 11, or von Willebrand factor deficiency. And from this alone, I can know while I am looking at the question, or I can try to figure out what they are actually trying to do here. Okay. So I know, for example, that if I am trying to pick vulnerable band factor, I need both problems in platelet and the coagulation factor. If it's factor 7, then it's a BTT. If it's factor 9 or 11, then it's a BT. Factor 12 is not even a disease, okay? So I know now what I am looking at. So when I read a 5-year-old boy, so it can be either X-linked or autosomal dominant. If it was a girl, then it would only be autosomal dominant, so I can exclude X-linked disorders. But here it's a boy, so nothing Significant. Comes to the emergency for knee pain and swelling. So I know it's a bleeding in the knee now because it's a bleeding question. So it's a coagulation factor problem, right? He reports he had a sore throat and a low-grade fever 1 week ago. Maybe it's significant because some diseases happens after viral respiratory tract. There is warm erythematous and swollen knee. Range of motion is limited by pain. There is ecchymosis with varying ages. The ecchymosis can throw me off into platelet problem. But let's look here. The patient's maternal uncle has a chronic condition requiring periodic IV infusion for bleeding episodes. When they mention maternal uncle, guys, how can it help us? Mentioning a maternal uncle, how can it help us, guys? What do you think here? What do you think, Sanusha? What do you think, Mihak? When they mention the maternal uncle, what does it help us figure out? Yes, amazing. It helps us know that it's probably an X-linked disorder, guys, right? That it's probably an X-linked disorder. This is the one that happens. Usually, they will mention there is a history in the maternal uncle. Okay, so we know it's an X-linked. Then let's read the labs. The hemoglobin is normal. The platelet count is normal, but does it exclude, if the platelet count is normal, does it exclude von Willebrand disease? It doesn't, because von Willebrand disease is normal platelet count anyway. It's a problem in the function. So how do I exclude von Willebrand factor? I look at the bleeding time. Here it's normal, right? So I know it's not von Willebrand factor from looking at the bleeding time itself. That's the most important thing. Then I look at the BT and it's also normal. So if the BT is normal, then it means BT smaller characters. So factor 7 is not also the correct answer. So now I have 12, 9, 11. Then the BTT is high, 62. So BTT is high, mean either 9, 11, right? Or 12. Sorry, 8, 9, or 11. 8, 9, or 11. There is no 8 here. 12 will be excluded because it's not even in the intrinsic pathway. But there is 9, there is 11. What do you think, guys? Would it be 9 or would it be 11, and why? So now I excluded A because BT is normal. I excluded von Willebrand factor because bleeding time is normal. I excluded 12 because there is no disease as 12. It's not even a hemophilia. But now I have factor 9 and factor 11. What do you think, guys? If I said maternal uncle, and which one is most likely? Then which one would it be then? Yes, most common. And X-linked will be the 9, guys. Okay, will be the 9. 11, that's very important. 11 is autosomal recessive. Factor 11, hemophilia C, is autosomal recessive. I remember it this way. 8 is factor A, right, Maria? And B is 9. 11 is C, hemophilia C, and I remember it this way, hemophilia C will be recessive. So they will not mention maternal uncle in recessive, okay? They wouldn't mention maternal uncle like this. So here it would be hemophilia B, guys, or Christmas disease, which is usually X-linked, similar to hemophilia A. Both of them are X-linked, okay? And when I usually go through these questions with myself, I always love to see, especially in these ones, why the other answers are incorrect and if I excluded them for the good reason. So 7, for example, it will cause prolongation of PT. So I excluded it for the good reason. Okay. Factor 12 is not even a disease. Okay. It's a clinically silent problem. It doesn't cause a disease. So I excluded it for the good reason. Factor 11 is autosomal recessive, okay? And it's very rare, okay? And it's mild. So this is something new, is that it's more milder. It doesn't cause severe bleeding like this, okay? So I excluded it for a good reason. And then von Willebrand factor, yes, it can cause prolongation of BTT, but it will also cause increase in the bleeding time, right? Here, this person have normal bleeding time, so it wouldn't be von Willebrand disease. Now, hemophilia A is more common. Hemophilia A is much more common. Okay, it's much more common. It's 6 to 8, or not even 6. I believe it's 7 to 9 hours per day, Andrea, and it cover 80% of the material, and you will get access to the recordings for 1 year. Okay. Now, so Rose is asking, deficiency of factors of coagulation doesn't have increased bleeding time, only increased bleeding time in platelet problems. That's a correct, Rose. Increase in bleeding time tells you it's a platelet problem, either number or function. Okay, either number or function. What if factor 8 was also the option? Then we would pick factor 8 as it would be more common psi. But I have never seen them trying to differentiate it between them. But factor 8 is more common than factor 9, than factor 11. Okay? Yeah, thank you. Again, now I know what they are asking, so I know where to focus on. So I know they are asking about an arrows question here, right? And they love the arrows question on the exam. So let's read. Let's read. A 23-year-old woman comes to the physician because of a history of easy bruises, okay, and heavy menstrual periods since menarche. Easy bruising, superficial. Heavy menstrual periods since menarche, deep. I guess I now have at least an idea of what disease they are talking about. Because first they are talking about a woman, so it's not X-linked, and they are talking about superficial bleeding along with deep bleeding, mixed. So I have an idea of what disease they are talking about that can cause mixed bleeding. She reports that she has always been an easy bleeder, and usually noting that minor cut while shaving her legs, often ooze for over an hour despite firm pressure. During her teenage, she required nasal backing, so superficial bleeding. Her mother and the maternal aunt have similar histories. Mother and the aunt and multiple things like this usually means that it would be autosomal dominant when you see multiple family members. So I know it's an autosomal dominant cause of mixed bleeding, right? Think about it, Zed. Think about it, Fadi, okay? Physical exam shows several 2 centimeter ecchymosis on the shins and the forearms in various stages of healing. There is no evidence of petechiae, gingival hyperplasia, or joint swelling. Temperature is fine, blood pressure is fine, pulse is fine, everything is fine. Further laboratory evaluation demonstrate a deficiency in plasma factor that facilitate platelet adhesion. Boom. Platelet adhesion would be either Bernard Solier or von Willebrand disease. But this person is having a mixed bleeding. So it wouldn't be Bernard Solier. It would be von Willebrand disease, right? Amazing, Iman. And now let's go through this. What was like von Willebrand disease? I always start with the arrow I am confident about. So I am confident that von Willebrand disease increase bleeding time. So I answer this first. The bleeding time will be increased. I am also very confident that von Willebrand disease will cause normal platelet count, right? Because it only increases the bleeding time without affecting the platelet count because it's a problem in platelet function. I am also confident that von Willebrand disease is very important for BTT because it's important for factor 8, so BTT will also be increased, but BT will be normal, so the answer would be B. How did I rule out Bernard Solier, Crystal? Because Bernard Solier is a problem in platelet only. It's not a problem in coagulation factor. This person is having deep bleeding. This person is having like mixed severe heavy ministerial period, for example. Okay, this heavy menses, for example, tell us that it's a coagulation factor. So that's a mixed bleeding here. Okay, the other thing is that the von Willebrand disease is the one that's autosomal dominant. It's the one that's autosomal dominant. Okay, the last thing is that they said there is problem in plasma factor, not in the receptor itself. Okay, not in the receptor itself. So here the answer would be B, guys. Okay, the answer would be B. No, Carolina, the 7-day course is usually me and the other like amazing tutors. So sometimes, for example, I explain neurology, cardiology, another tutor that is scored 260 or 270 plus will explain the best system he can also explain. Okay, so it's usually different, like 7 to 10 tutors that will explain the best sessions and the best like systems. Okay, now let's go here, guys, and see. A 32-year-old woman comes to the physician because of a 4 month history of progressive fatigue and shortness of breath when climbing stairs. She also reported a recent persistent craving for ice cubes, which she shows throughout the table. So again, I did a problem which is I didn't read what they are asking. If I read what they are asking, I know they are asking about an anemia. So I know here from like craving for ice cubes that this is called the bica, right? And this would be what, Mustafa? This would be what Ajay had. Amazing. This would be iron deficiency anemia. Okay, guys? Why is this? Because this person is having heavy menstrual cycle. Her menstrual cycle is very heavy. She has pale conjunctiva tachycardia, and they're asking what would the lab shows. So what would the lab shows in iron deficiency anemia? And as you can see, the mean corpuscular volume is low because there is problem in iron, and it will cause decrease in the mean corpuscular volume. So what do you think, guys, here? So I will give you a time to think about it, and then we can do it with each other. Okay, perfect. Amazing, Amir. Amazing, Elena. Very good, Mihak. Amazing, Mustafa. Amazing, Sarah. So let's go through this rosé. So this person is having iron deficiency anemia. What do I start? I start with the easy ones I am confident about. So I am confident that serum iron and the ferritin, both of them will be low. Can you see even in the NBMEs, if you start with the easy ones, you can answer the question. You don't have to know the four options. Sometimes knowing two options or three options can give you the option, the correct option. Okay. And then for the sake of completion, I know that the capacity is high. Why? Because I don't have iron. So I have too much capacity in the transferrin because the saturation of transferrin is very low to carry iron. I have huge capacity to carry iron because I don't have iron. And then the distribution width itself, distribution width will be high. And this is always high if you have iron deficiency anemia. Okay. Iron deficiency anemia will cause increase in the distribution width. Okay. So the reason this ratio of distribution width will be high, guys, if I have an iron deficiency anemia. And this sometimes differentiates thalassemia from iron deficiency anemia. Okay. That's the only thing I want you to know, Mihak. Distribution width will be high in iron deficiency anemia and it will be low in thalassemia. It's only high in iron deficiency anemia. That's very important. Okay, so that's what I want you to know. What is the street distribution width? It's different cells in size like this. The cells will be different in size. It always happens if you have nutritional deficiency like iron deficiency anemia. Okay, now, so here's the answer would be the E, guys. Okay, now, what's your diagnosis from the picture? What's your diagnosis? So can you see this? Can you see this, guys? Amazing. Perfect. Perfect. Perfect, Nasania. This would be multi-segmented, right? Multi-segmented neutrophils. Amazing. So this would be megaloblastic anemia. Either B12 SARA or folate. We don't know yet. We don't know yet. But this person here, okay, is eating only toast, tea, and the canned soup, and neurological examination is normal. Neurological examination is normal. So is this folate or B12? Neurological examination is normal. And what would be the levels then? Oh, sorry. I so here. What do you think? Amazing, amazing, Shrani, amazing, guys. Perfect. So I will not say it, but can you tell me what will happen then? Would it be A, B, C, D, or E? Perfect, Rania. Perfect, Christina. Amazing, guys. So we know that it's a megaloblastic anemia, so the MCV would be high. Then we know that in folate, it's a folate, you guys, because the neurological examination is normal, right? So how do I approach this? I know folate will cause increase in one thing. B9 increase in one thing. B12 increase in two things. Folate will increase homocysteine, what will cause normal methylmalonyl A, right? So the answer would be A. Now, what would be the reticulocyte count? It's not hemolysis, so it would be low. It makes sense. So the answer here would be A, guys. Increase in mean corpuscular volume, increase in homocysteine, normal methylmalonyl CoA, and decreased reticulocyte count. B, on the other hand, will be B12. Okay, this will be B12. Perfect, guys. Perfect, perfect, perfect. So here, the answer for this one would just be A. That's amazing. Now, let's go for this one here. Okay, and let's change the theme because this is very hard. So, yes, Andre, and that's the thing, Andrea, is that I didn't answer reticulocyte count at first because I don't even know. Me myself as Karim, I don't even know the reticulocyte count will be what in B12 or B9, right? So that's why I left it at the end because maybe it's normal, maybe it's low. Maybe for some weird reason it's a high, but I start with the ones I am sure about. Okay. Now, let's see in this question, guys. So they are telling me that this person is having like ruptured appendix and peritonitis. He has been receiving piperacillin tazobactam due to prolonged ileus, post-operative ileus, okay? And he has been strictly nothing per oral and receiving only IV fluids without nutritional supplements. Today, the nurse notes significant oozing from the patient's surgical incision and the multiple new ecchymosis at the peripheral intravenous catheter. Oozing of blood, we said it can be DIC, right? But for DIC to be always the diagnosis, I need to look at the decreased platelet. And this question is extremely hard, so let's continue and see, is it DIC or not? He has no prior history of easy bruises or bleeding disorder. Physical exam shows distended, non-tender abdomen with dark blood seeping through the dressing, oozing of blood. Now let's look here. Hemoglobin is decreased a little bit from the bleeding. Platelet count is normal. Oh, if I see platelet count normal, that will never be DIC because we know DIC decrease platelet count and they increase everything else, BT, BTT, whatever. So it's not DIC. So let's continue and see. It's also never HIT, Kahla, because HIT is heparin-induced thrombocytopenia. It will also decrease platelet count, so it's not the correct answer. But let's continue. BT and the BTT are high. Both of them are high. Okay? So BT and BTT are high. And they're asking which of the following condition would most likely produce a similar coagulation factor abnormality. So let's take it one by one because this question is hard. BT is factor 7. BTT is factor 11, 9, and also 8. And we also, both of them can be high if you have problem in factor 2, 5, 10. So my question for you guys, what can cause problem in factor 7, okay, in factor 9, and in factor 10 and 2 to cause increase in BT and to cause increase in TTT? What can inhibit factor 9, 7, 2 like this? 1972. What is this? Yes. Very good. Very good, guys. Amazing. Amazing. Perfect. 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 So this would be warfarin, guys. Warfarin function is that it inhibits the activation of vitamin K. Inhibit enzyme called epoxide reductase. Vitamin K is important for something called gamma carboxylation of the coagulation factors 9, 10, 7, 2. And that's why if you have warfarin therapy, for example, you can get increase in BT, BT. But Karim, you told me that we monitor warfarin with BT only because usually warfarin inhibit factor 7 first. And that's why if you need to monitor it, you monitor it with factor 7 or BT because it would be accurate. Because factor 7 has a very low half-life or short half-life. But if you have warfarin overdose, severe warfarin overdose, it will not only inhibit 7, but it will also inhibit 2, 9, 7, and 10. So it will increase in BT and BTT. Okay, Ahmed? So that's the thing. So the answer here would be warfarin therapy. Any other answer will not work because hemophilia A will activate BTT only. BTT only, not BT. So wrong. Heparin, Heb. BTT only. Or sometimes it can cause something called the heparin-induced thrombocytopenia, decrease the platelets. Wrong. This person have increase in BTT and BT. Okay. Von Willebrand disease will cause increase in BTT, but not BT. Wrong. ITB will cause decrease in platelets. So wrong. So does it mean warfarin causes DIC? No, yet it's similar to DIC. Vitamin K deficiency can mimic DIC because it increases BT and BTT also similar to DIC. And that's why it can cause this oozing of blood. Usually oozing of blood happens when your coagulation factors are zero or they are literally deficient. And this is what commonly is associated with DIC, but it would be here the answer would be warfarin, which can be similar to DIC. But it's not DIC because platelet count is normal. Okay. So that's regarding this question here, guys. Okay. So that's it. Amazing, amazing work. And so the answer here, okay, let's answer it warfarin just in case the question was not warfarin and we answered it for the wrong reason. Okay. So yeah, this was warfarin. So that's it, guys. I will again post my number in the chat. Okay. If you just need anything from me. So let me post the number here. And we also made a community, and that's like the link for the QBank. 1 second. So that's the link for the QBank itself, and that's the link for the community we have made. I need you to join here, and I will let you know of the upcoming webinar. If this webinar was very good, guys, thank you so much, Kara, and I really appreciate your kind words, guys. Thank you. Thank you so much, Ablash. And if this webinar like was helpful, we will try to always have similar webinars like this, guys. Okay, each Saturday. Okay, maybe sometimes it would be me, and sometimes it would be other ones of the amazing tutors. Okay, I will tell you where is the recordings are usually like posted. So it's posted within 2 days, for example, in this channel. I will send you this channel. Okay, you will see even my previous recording on it. So my previous neuroanatomy recording will be on this channel. It's like YouTube channel. You can also see my videos that I have done for the high-yield radiology images and some other helpful webinars. And if it was me, I would just like stay with you guys. And I really wish that I can stay more to finish all the hematology and the other sections. But hopefully we'll try to do this every Saturday. Thank you so much, guys. I will be waiting for you at the webinar and at the community of WhatsApp that I have sent to you. And again, if you need one-on-one tutoring, you can ask me or any of our amazing tutors that score 270 plus on the exam. And you know the drill. Thank you so much, and I will see you later. Thank you. Bye.